I'll try to keep this real short and sweet so we have time for questions. I'll pick up the pace. So, like Paul, I felt like, okay, this treatment monitoring and data collection, that sounds boring, right? So the challenge then is if you can get the slides up. Thank you. All right. Yeah, so that's boring. Well, but I'll try to make it as unboring as possible. So bear with me. This is the AKI CRT conundrum, right? So we have an injury that sort of happens maybe at home. Old dude getting septic. His wife tells him to go into the ER, and he's like, "No, I'm fine." And you have a patient's delay sometimes, or somebody gets sick in the ward, or you have a surgical mishap. We don't really know exactly when the kidneys start to hurt. What we do know is we have an injury evolution time. We eventually have a functional decline, and we pick that up by mostly using old school functional marker like creatinine, urea, urine output, maybe cystatin C. But we're sort of late to the game, right? We're sorry I'm late. It's just who I am as a person, which sort of is also my thing. So CRT is almost always late, and we've heard many times during this conference and during the years that early diagnosis and detection might lead to better or more timely intervention, and that could be earlier renal replacement therapy, or it could be directed medication. Doesn't matter. We're late to the game. Medications are now in phase 2 and phase 3 trials, but at the moment we're stuck with supportive therapy, right? We're stuck with CRT or other means of RT, and so with that in mind, how do we? If I have to address this semi-boring question, how do we monitor RT? How do we treat the monitoring, or how do we monitor treatment? And I'd like you to take just 1 minute to think about how haphazardly we're looking at CRT versus other interventions or other organ supports in the ICU. I think this troubles me. So if we look at mechanical ventilation, right, we have loads of calculated and measured parameters that we look at, and treatment effects. We look at blood gases, and we would never dream about starting all patients, the 40-kilo young lady and the 120-kilo old man, with the same kind of respiratory treatment parameters. That sounds insane. And the same goes if we look at vasoactive or inotropic drugs, right? We basically know how to monitor that. We would never do a one-size-fits-all, and nobody would dream about doing a study comparing 2 doses of norepinephrine. Let's start some patients on this dose versus that dose, and then just monitor the effects. We would find that hilarious and just stupid. Of course, we look at blood pressure and other parameters of treatment. We do frequent echoes, and we have invasive monitoring. This is commonplace in all ICUs, I think. And for you intensivists out there, you're like, yeah, of course. But when it comes to antibiotics, it's a bit more sketchy, but still we follow our treatment. We look at CRP, PCT, temperature, frequent CT scans, or other radiological things. When it comes to CRT, it's more complex. And we've gone through these different modalities with different effects on different types of solutes. I'd like to just show you how we at Karolinska in Stockholm, Sweden, where I work, decided to sort of cut through this mess. So what we did was we started CRT treatment using citrate back in 2001-2 with our homebrewed method, and then that evolved, and now we use one of the industry methods using the Gambro-Baxter Prismaflex concept, and now the Prismax concept. Anyway, what we did was, and sorry, this is Swedish, but it doesn't matter. We force all the clinicians to think about the indication. They have to state what kind of indication they have, right? Is this a septic AKI? Is it pure hypervolemia? Is it some weird outlier like an intoxication or hyperthermia or something like that? because that will affect how you then evaluate your treatment, of course. So, and then we go on to say, so, okay, what is the status of the patient when you start the treatment? What's the body weight? What's your creatinine and cystatin C and urea? This gets us a baseline at CRT initiation. And then, what we do then is, when the treatment is started, we then force the clinicians to plot in by hand how, this is like the date, right? So you start here and you fill in your little form, and also the prescribed dose, and if you use heparin or citrate, and then you add up what happened to the creatinine, what happened to the blood urea nitrogen, what happened to the cystatin C. And the point we're trying to make is to sort of force our fellow clinicians at our ICU to treat this treatment like you would with other. You cannot then just start all patients with the same effluent fluid, the same fluid removal rate, ultrafiltration. You're sort of forced to evaluate your treatment, and you could actually have two, the archetypical 70-kilo males. I don't see them that much, but they're in the textbooks. So you have the two 70-kilo males, and they both have septic AKI, and they can both come into your ICU with a KDIGO 3 tripled creatinine and be sort of severely oliguric, and they can both have the same exact machine treatment, with the same effluent rate, both on CV-HDF. And this one guy, the 70-kilo guy to the left, his urea will just drop by 50%, and creatinine will go down as well, and cystatin C will go down as well. And the other guy, with the same apparent reason for starting CRT, is in the septic AKI and is the semi-shock, some pressors and whatnot, intubated. He will not change his values at all. And that can depend on not only how the circuit has worked, but also the rest renal function. And we have no real way of accurately measuring that. So what we then say to our younger and also our senior colleagues who for some reason find this machine so tantalizingly difficult to get their head around is, okay, doesn't matter. You can start the treatment the same way for these persons. But if this one person has just dropped a lot in urea, maybe you can just dial the dose back a bit. You don't have to get that. And this one other person who's just stayed the same or even increased the creatinine and urea, well, maybe you have to increase the dose. And so this sort of forces them to think about this treatment just the way we think about all other organ support systems in the ICU. And maybe all of you are, much smarter and more well-read than we're barbarians from the north, right? Swedes. It's dark and we don't have much, fun. So maybe we all thought of this. But it's so dark and so gloomy in Sweden that it took us some time to sort of crack this. But I think that this has improved our practice a lot. This is a very pragmatic way of just enlightening the people and just making them see this particular treatment just like they would treat antibiotics or vasopressor support or mechanical ventilation. You force them to evaluate the treatment. And you can get information like, okay, so one patient has to go to surgery every day and CT scans and whatnot, hyperbaric chamber treatment, whatever, and you have a lot of downtime, and then they will see that, okay, so this treatment was sort of non-effective, exactly what Paul talked about. You have a lot of downtime, well, then you tweak it up a bit. You maybe have to aim at 40 mils per kilo per hour to actually get an equivalent to 25 if you have a lot of expected downtime. And you'll see this using this kind of simplistic chart because you can evaluate your effects. And we also do this since about 5 years, I think. If we have a septic patient, if the patient is on antibiotics, and septic AKI is the main driver, at least in my general medical surgical ICU, septic AKI is the main force behind behind AKI and thus behind CRT treatment, we measure concentrations of meropenem, pip/tazo, and vanco. So we make sure that we don't drop below the MIC value. And this brings me back to my main concern when it comes to the dose studies. I'm concerned that the high dose arms in all the randomized trials actually have removed some of the antibiotics because septic AKI is the big driver. We know that antibiotics actually works as a treatment for sepsis, right? And then you initiate a treatment that might, in the high dose arm, actually remove some of that potentially beneficial medication. So I'd like to, have a time machine, go back and A, de-elect Donald Trump, and then B, also redo the studies with measurements of antibiotic dosing in the high intensity and low intensity groups. I don't think it's that important because when we measure these drugs, these common drugs for sepsis in the general ICU settings, it's only if we have really, really high doses and really, really like big overweight persons that we sort of drop close to MIC values below below MIC values, basically. So if we have really big persons and high dose CRT, we tend to we jack up the dose a bit. And we just measure it because again they have different renal function, and just by not guessing anymore, by measuring the dose, we can get it right. Another concern actually is the removal of low molecular weight heparins, which is, these are a mainstay. The patients they're bedridden, and low molecular weight heparins are beneficial for survival. That's been shown in numerous studies for the last 30 years. And if we remove those, it shouldn't be good. So another concern that I've talked a lot, and I invite you to think about this, is are we removing PCT and CRP? We measure these values daily. I actually have a really big CRT database. I will intend to look at that. Is CRT, especially if we have high dose CRT, does that remove these markers of inflammation, these biomarkers of inflammation and infection? Interesting. I also want to just end with a couple of words of caution when it comes to creatinine. This has to do with a study I did with my PhD student Bo Ravn and John Prowl. It's a Karolinska cohort of 3,000 about patients. This was published in Critical Care Medicine like a year back, where we saw that, when we discharge patients, and this is patients both with and without AKI, with and without CRT treatment. So this is just a big chunk of Swedish ICU patients, right? When we discharge them, we can see that looking at quartiles from low to higher creatinine and low to higher cystatin C, you can see that creatinine has this kind of U-shaped curve with patients with very low creatinine at discharge. They have a higher mortality than the mid values, whereas cystatin C, in contrast, is like a linear curve. And shown in the same picture here, where you can see that, so ICU discharge, last day of ICU or the next to last day of ICU, you can see that discharge cystatin C is a linear curve with 1 year mortality. And creatinine is similar. However, if we adjust this curve with cystatin C for creatinine, nothing happens. But if we adjust the creatinine curve for cystatin C, i.e. removing the renal component and ending up with a measurement of muscle mass, you have an inverse curve. So if you look at creatinine in this sense, it's a marker of catabolism and muscle wasting. So I think this has implications for treatment monitoring in the effect of, if we want to find patients who should be followed up by nephrologists, if we want to do targeted follow-up studies, I think using the KDIGO criteria at discharge could lead us into a wrong path. So I think especially for patients staying for a long time in the hospital and or in the ICU, because they're likely to be catabolic, and using, like blindly using KDIGO guidelines might, you might end up barking up the wrong tree, and patients with better creatinine actually are only patients with less muscle wasting. So a word of caution there when it comes to follow-up studies. So in summary, why not, if you're not already doing it, try to adopt this super pragmatic Stockholm Swedish approach for evaluating your treatment, just like we do with any other organ treatment. Look at your indication, why you're starting the treatment, evaluate your prescribed and your delivered dose, and see how that sort of ends up with regards to the markers of renal function we do have. Novel biomarkers will, I think, come into play. I was part of the STUT study, and I'm fond of the TIMP2 and IGF-BP7. We're not using them clinically now, maybe because I have some conservative bosses who are skeptical against everything, but I think they will come into play more and more. Old school functional markers like creatinine, urea, and cystatin C are important, but follow the trends. So evaluate your treatment by looking at the trends. And that goes for weight gain or weight loss as well. So you will evaluate in that sense both your fluid balance and your treatment effects. And consider monitoring antibiotic levels in plasma if you have septic AKI patients. And lastly, but not leastly, if you plan on doing discharge follow-up studies, trying to monitor patients with risk of later CKD, use creatinine with caution, because it's complicated if you have patients who have been bedridden for a long, long time. And with that, I thank you.